Good afternoon. We are here at the Veith meeting, which is a fantastic meeting, probably the best in the world. And there have been many topics which has been shown today and yesterday. And one of the major topics were about AAA treatment. And there are many discussions, especially about the rupture AAA. And the question is are they better treated open or on those? There have been many studies, but there are still many questions. So we are here with very clever, brilliant surgeons and scientists who can give us some their opinion about these important topics. So Dr. Barnes, Janet Powell, and everybody knows Frank. So
yes. So what I would tell you is this has become somewhat of a controversial topic, but I work in an institution where we see more ruptured abdominal aortic aneurysms than any hospital in this nation. And it's 30 to 40 a year. And we implemented a strategy for managing these patients with an endo-first approach and saw a dramatic reduction in mortality at our own institution, from 58% all the way down to 16%. And so clearly EVAR shows a benefit for managing these patients. What we're really excited about today is identifying those patients who have a 100% mortality risk. How can we identify those patients before taking them to the operating room so that we don't have a futile situation? And we've identified 4 factors that we're going to present here at this prestigious meeting. And those factors are age, over the age of 76, a serum creatinine greater than 2, a blood pressure at any time of less than 70 millimeters mercury, and a serum pH of less than 7.2. If you have all 4 of those factors, you have a 100% mortality risk, and surgery is futile, either open or endo.
Okay, that's a good point. Janet.
Thank you. Well, I come from the United Kingdom, where actually we have a screening program for abdominal aortic aneurysms in men, which is driving down the number of times that we actually see ruptures presenting, particularly in men. But we ran a trial which looked at not straightforward endovascular repair versus open repair, but taking people as they pile into the emergency room. Should a strategy of endovascular repair as a first option be better than just rushing them to the operating theatre for open repair? And initially you might have thought that our early results were disappointing at 30 days because we failed to see any significant difference between the 2 groups, except for women. And interestingly, throughout we followed all the patients for up to 3 years, and at every time point, women did far better with an endovascular strategy than men. However, our results were quite interesting in that, having followed the patients out for 3 years, at this time point, midterm, we could see that in fact the endovascular strategy was much better for everybody. Still, particularly for women, as I think I will show later on today. By this time, it's good for everyone. It's particularly good for the patient from the patient perspective. Because what it does for the patient is it gets them home sooner. Every patient wants to get back home rather than end up in another hospital or a nursing home or geriatric care. It gives them better quality of life, particularly in the first year after rupture, and it costs slightly less. So in our very cost-conscious health economy, it's got to be the winner.
Okay, great. Just one quick question. How many of these patients have an anatomy unfavorable for EVAR?
Approximately 2/3, 64% if you want the exact number. Yeah.
And do you push the technical limits like Mario Lasha does by doing gymnasts and so on?
We do. In our series, 73% were candidates for, it was exactly the opposite. 73% were candidates for an endovascular approach. Okay. But that involves doing on-table fenestrations for some patients and to extend that seal zone a little bit higher. But roughly a quarter were not endo candidates. But you can still use an endovascular approach. you can place an aortic occlusion balloon under local anesthesia, and you have the clamp on the aorta before ever putting the patient to sleep. So it helps with the open repair.
But that's
as well.
actually quite similar, because we have found that 2/3 were suitable.
Oh, you did? Okay.
Yeah.
So okay. So it
So Frank, you are pioneers in this field. You were the first to treat a rupture
I'm the
aneurysm.
oldest one in this group, and I had the good fortune a long time ago in 1994 to do the first EVAR for ruptured aneurysm. And we were so excited by that case because he was completely inoperable by standard open operation. He did remarkably well. I had the good fortune to do 14 other cases that were similarly inoperable by standard open surgery. And most of those patients survived. I think 2 of the 14 didn't. And so I became an early enthusiast. And I happened to have been swimming upstream for many years, trying to convince the rest of the world that EVAR, if it can be done, is the best way to treat ruptured AAAs. And now pretty much the rest of the world agrees. Janet, despite her randomized trial and some disagreements that we've had before, is now in agreement. And I think anybody who's capable of doing EVAR in an organized, structured institution, if you can treat such a patient by an EVAR, that's clearly the way to go. Obviously, there are some patients that may not be suitable. There may even be a few that are too sick, don't have a good brain or whatever, that are best not treated. But in my opinion, even some that have the criteria that Ben pointed out, I think some of those patients can be treated successfully by EVAR. And I've had such patients come in with a coat and a tie back working after fulfilling at least 3 of those 4 characteristics. So I guess I'm an optimist about EVAR. I'm a supporter. I think the rest of the world, if they're not capable of doing it, should learn how to do it, because that saves lives and treats patients better.
Well, it seems that everybody agrees on that, but I have one more question. It's more kind of not EVAR. I agree with you. We were also the first in France to do that in my institution. But then it's a question of organizations. If the rupture patient come to let's say general hospital, the guys do some endo, but little knowledge, probably his chance of surviving is very low. And I don't know, in your country, obviously there are big centers, but in France we are trying to develop what we call SOS aortic centers for rupture, dissection, and so on. And there are in Paris, there are 2 or 3 centers now, and it seems to work pretty well, because when the GP or the urgencies have a rupture aneurysm or suspect a rupture aneurysm, he has one number he has to call. And the guy who takes the call is an anesthesiologist. And he say, well, we can take it if the CT, the angio suite is okay, if there are the surgeons, if the OR is okay, and so on. And then it seems that these organizations allow more EVAR to be done, but also more life to be saved. So
Absolutely. I mean, there's no question you need 2 things. You need the commitment on the part of the surgeon or the radiologist or whoever is doing these procedures has to be committed to it 24/7, and you need an organization. And that organization can be what you're talking about, but it can be actually simpler. In the early days, we did everything. We stocked the equipment where we knew where it was. We didn't need nurses. We didn't need x-ray techs. We needed the patients to be sent directly to the unit with a CAT scan or without. And clearly, even despite our primitive attempts, because we didn't have all the things that you guys have, our results became very quickly better. And so commitment and belief in what you're doing is part of it. And of course, you've got to have endocompetence. And in the beginning, we weren't even endocompetent. We still had better results. Right. I went to visit Ben. He's far and away better at this than I ever was. So he gets even better results.
But I think one of the issues that remains, even if you have one of these centres, is how you manage the patient en route to the centre where they're going to be treated.
Right.
I think you've raised this in your 4 criteria, and one of them I'm would agree with, and I know Frank would not necessarily, which is the blood pressure criteria.
Yes.
These are relatively old people. Most of them have probably been hypertensive, especially by the new American criteria for hypertension. And how should we manage their blood pressure on the way to the hospital? And I think that's an outstanding question.
Well, and so to speak to the whole concept of regionalization, I think these centers are critical for managing aortic catastrophes, not just ruptured aortic aneurysms, but aortic dissection and transection, which we all manage. But we can divide it into the pre-hospital, the hospital, and the post-hospital categories. And the pre-hospital system that you're talking about has to be robust in managing the patients up front. And we endorse hypotensive hemostasis or permissive hypotension. Allow the patient to be hypotensive. Don't hit them with too much in the way of IV fluids and IV fluid resuscitation. If they're mentating, if they're able to talk to you, if you ask them their name and they can recite it to you, they're perfusing their brain and they don't need more fluid. If they don't mentate anymore, then you can give them gentle fluid boluses, but keep them hypotensive.
Let me just add to what Ben said, because in the beginning we didn't believe in this. But we found one thing, that a lower blood pressure stops bleeding.
Yes.
And again, as you say, we used to say if the patient is moving and talking, he's adequately resuscitated. And we used to put a clamp not on the aorta, but on the IV tubing. Because our anesthesiologists were trying to get the blood pressure up.
Right.
Obviously, the patients, maybe you say they shouldn't tolerate it, but they did, provided one then got rapid control of the aorta and could take the clamp off, and they could then be refilled.
You know, Frank, this is an anecdote, but when I first got to Harborview Medical Center, the day one in 2007, I walked into the ICUs, and there were 5 patients, 5, that had open abdomens with mesh sewn in because they had abdominal compartment syndromes from a ruptured AAA, and they lost their abdominal domain because they got flooded with fluid. Right. We haven't had that patient in our hospital in 5 years. I haven't seen a patient that has had a mesh for an abdominal compartment syndrome where we weren't able to close them within a day or two.
I think one of your criteria is 70 millimeters of mercury, isn't it?
If it's less than that,
yes.
Yeah. But they have to meet all 4.
Less
than 70 at any
that's
time.
his criteria for non-operability.
Yeah.
But the point is, they can tolerate several of our patients arrested. We resuscitated them, we left their blood pressure low, their heart starts again, and we go through the procedure. Right. In many of those cases, we put a balloon in to the aorta, and then the pressure right away comes up. Right. You put the graft in, take the clamp off, the balloon out, resuscitate them, and they survive. Yeah. Not always, but some of them.
You raise a very important question, is a compartment syndrome. And we know we have published something of that some years ago about the colonic ischemia following a rupture. Yes. It was in the range of, let's say, 20%.
Yeah, now it's 5%.
Yes, less, but still there are some. And then the compartment syndrome, and then the easy colonoscopic investigation, in my view, is very important. Even maybe you have to do it systematically, and if you see a colonic ischemia, try to do something. So what are your criteria to decompress the abdomen?
So it's based on the judgment of the operating surgeon. So we will look at peak airway pressures above 30. We'll look at, we don't measure bladder pressures, because if we think that the patient has an abdominal compartment syndrome, we just open their belly, we evacuate the blood, we pack it, put a vac pack on, and then bring them back within 24 to 36 hours and close their abdomen. And they're pretty easy to close after you've adequately resuscitated the patient.
Mario Lachot, who was supposed to be part of our group today, has developed a very slick system. I spent time with him. He does measure bladder pressures, but he does a lot of other things. And the important thing is he does not believe that the blood should be evacuated because they start to bleed. You know, you just take a little bit of the blood out.
Just take whatever the blood is.
The loose blood.
Yeah.
And then in some cases leave the abdomen open.
Don't go into the retroperitoneum.
With exactly what you're talking about.
Right.
And then he had a beautiful system for getting the abdomen closed. And one of his patients, who I observed when I was there, ended up with a linear incision, linear scar, no hernia,
Right.
with this nice system for closing the opened abdomen. But it obviously increases morbidity. It's not a good thing. But some patients get it even with fluid restriction because of the blood.
Right.
So is it, or more questions to come?
Sure, ask you, I know. We can always edit it out.
You feel that the mortality is declining after rupture aneurysm? It's clear in every country.
It's clear.
And I know that your randomized trial have included patients with stable and unstable hemodynamic, and but the French and Dutch trial have involved only patients with a stable hemodynamic, and they could not find any difference. But I know you raised the question that the main patient who will benefit from EVAR is
The benefit of EVAR over open repair is the most critically ill shock patient who wouldn't survive an open repair, but who does survive an EVAR. And if those high-risk patients are excluded from the study, obviously the study isn't going to show benefit.
I mean, that's exactly why we had some patients who died before they actually had their repair, because, when they got to the operating table, the anaesthetist said that they've had it. And that's because
Right now, we didn't do our cases under local, which I think is a major advance.
I do.
You do.
We do.
You do. Mario with shotgun.
Or no anesthesia.
With no anesthesia. Well, they keep moving around.
I stick a needle in their femoral artery, and if they flinch, if they move, I give them local anesthesia.
Correct.
If they don't, I just keep on going.
But the idea of using general anesthesia, which we did, I think was a mistake. We did it because we had to have them hold still so we could do our video and fluoro.
Well, in terms of graft, you try to do bifurcated graft or autoimmune and fem-fem?
absolutely.
Always.
I tell you that the only cases of graft infection we've seen after EVAR are in the femoral limbs of a fem-fem crossover with an AUI.
Yeah.
We haven't seen any cases of graft infection with a bifurcated graft.
No, I think an anatomic reconstruction with a bifurcated graft is much better. It's much more durable as well.
A word of history. The reason we did the first case was we had a graft that was available and sterile on our shelf. That's not necessary anymore because now everybody has a stock of grafts.
That's the other point. That's why centers are important, because you need a lot of grafts.
Yeah, but if you want to be committed to it, you're going to have a stock of grafts and other equipment. And I completely agree that a unilateral with a fem-fem is not the way to go, because if that graft closes, the pelvis and everything else is ischemic. So bifurcated grafts are the way to go.
I agree, but then there is sometimes some trouble by getting into the short limb, cannulating the gate. So I know with the balloon, you put the balloon, stop the bleeding, and then cannulate. But sometimes it takes time, especially in these patients who have a very angulated iliac arteries and so on.
So there are a couple of grafts out there that can be used that have a long main body. And if you size the graft, if you have the luxury of having a huge inventory, like we do, we have 300 aortic stent grafts on our shelves.
Wow.
So we can...
You can open a bank.
We can open the bank and put whatever graft in, but it's important to have the right size graft for the patient. And we always size that contralateral gate all the way down to the aortic bifurcation, which makes gate cannulation very simple.
That raises another issue. If you've got a city like Paris, for instance, and you've got 2 or 3 named institutions, should you have a central bank of devices for emergency devices so that you can actually have a better choice?
You mean within a city?
Yeah.
Within a city,
I suppose. But the other thing, people talk about using the balloon on all cases. That's a mistake. We feel, and I think Ben agrees, and you too,
our guys
Jean-Pierre,
don't like it.
we should use the balloon only when the patient really collapses. When they stop talking and they have no blood pressure.
That's
balloon.
right.
So you have the wire in, it's pretty quick to get the balloon in.
A long sheath to support the balloon. We put
Absolutely
it up at T12 vertebral body every time. And then if they're unstable like that, then we say to the anesthesiologist, go ahead and put them to sleep. and we'll resuscitate the patient now with fluids, let the balloon down to get your graft up into position and complete the case.
Right.
Well, another question is about the mid or long-term results when these patients survive. I know, Janet, you told us that there were more reinterventions after rupture than after
After elective repair.
repair.
It does seem to be about twice the rate. And I think some of the reasons for this are because people are keen to resuscitate the patient. And I think sometimes perhaps the iliac seals are not perfect first time around. And other issues like that. But they've saved the patient and they can come back and do it again.
Yeah, they're much less morbid procedures.
And you can do it all under local. They're all endovascular procedures.
Well, the other point, you got to leave the sheath up to get the balloon out. So the sheath not only supports the balloon, it facilitates your getting it by the graft to get it out. And we don't deflate the balloon to put the other sheaths up. We maybe deflate it a little bit, because if you deflate the balloon, the patient collapses again.
Yeah.
And the other trick is you got to seal the hole in the aneurysm before you lose balloon control.
I think there's another issue too after the repair. You might expect that you wouldn't see that much limb ischemia after EVAR, but you do, almost as much as after open repair. And I'm quite surprised that people don't think of having any routine surveillance in the first couple of days for limb ischemia, because it's quite a common problem.
Well, then you think you should heparinize the patient?
I do, selectively, because when you have someone who comes in who's profoundly in hemorrhagic shock, those are patients that you can probably get by with just heparin flushes, especially if their anatomy is conducive and it's a 10-minute fluoro time and a 30-minute case. But some of those patients who are stable, we will give them about a 50 unit per kilo dose.
So some of the cases of limb ischemia is because we didn't heparinize the
and
patient.
You had big sheets in their iliacs
Right.
for a long period of time.
But there are many other factors that can cause limb ischemia. So that is a major factor.
And it's one that really worries patients.
Almost as much as a stroke.
That's right.
Yeah, that's right.
Okay, I think our time is out now, and you all save patients, so congratulations.
Thanks.
They stopped taping 10 minutes ago.